Welcome to the Inspired Caring Podcast, where women who are in the messy middle of this big, beautiful, and sometimes chaotic life are finding inspiration and resources to care for themselves and figure out the best options to care for their aging loved ones. How we take care of ourselves today impacts how we are aging tomorrow. This podcast will help you feel seen, centered, and aligned. Everyone that relies on you is so lucky to have you in their life. The Inspired Caring Podcast is your reminder that the number one person that counts on you is yourself. Congratulations on being here in this moment. Let's dive in and be inspired. Today's episode of Inspired Caring is going to be very informational because I think this is a piece of the puzzle that families really struggle with. And we feel like there's so much happening behind the scenes. And Steph Madej is here to help us have a better understanding of what is actually happening when our person is in the hospital and they are working to discharge them. The discharge process. So thanks for being here, Steph.
Yeah, thank you. Happy to be here.
You're a nurse.
Mm-hmm. And I've been a nurse for like 10 years. And I worked in a lot of different roles. So I think it's kind of good that I have that experience in administration and in assisted living, home care, and the hospital, and the office and on the floor. So I really get to see it from like every aspect over the years.
And you have a very solid understanding when someone is being discharged from the hospital, if they're in a building, kind of what you're looking for, or any red flags specifically, or if someone is going home with home health, what those needs could look like. So
right.
I think the scenario that just frequently comes to mind is someone ends up being actually admitted to the hospital, which I think that's actually a good place to start. Sometimes we go to the hospital, people aren't getting admitted.
Right.
Why would that be the case?
If they can treat somebody in the ER without having to admit them. So technically you have to qualify, you have to have like an admitting diagnosis for insurance to cover it. So if they can treat you with oral antibiotics or something simple in the ER, they're going to send you, if you have a safe discharge plan, I'll say that. If you have a safe plan, they'll send you back to where you came from. But say you do come in and you don't have a safe discharge plan, but you're technically okay, they're going to have to admit you because it's not safe for you to go back home.
Okay. So what constitutes a safe discharge plan? What is the hospital looking for?
Well, there's a lot of things like, somebody's falling, or are they taking their meds appropriately? Do they need rehab? Do they have the mental capacity? Do they have dementia? Do they have somebody who's cooking meals for them, or can they do that on their own? So really just the overall picture, there's really a lot of pieces that go into it, but pretty much if they're taking good care of themselves and thriving, and if not, then what resources can we provide them? So that's kind of where that piece comes in. And again, there's sometimes that family members can't take care of them, or they can't take care of them and they just bring them to the hospital, which honestly is the right thing to do because we're the ones who can help with that placement part of it.
I think so often I've heard of people who, let's say it's their elderly parents, and one parent is taking care of the other parent, and things have just gone south. So now they've come to the hospital. Mm-hmm. And when a family member can also be in the emergency department with them, mm-hmm. and the assessment is being made, like, is it safe to actually send this person back home? If it's another elderly parent that is providing the care, sometimes that feels like maybe not a safe plan.
Sure. Yeah. And there have been times that happens. And I think so there's always a social worker and a care coordinator assigned to each patient. And then you're going to have your doctor and PTOT, so your therapy department. I think having that whole team together, everybody can decide, like, is that person safe to go home? And honestly, if it's a couple and they're married, that spouse is going to be in the hospital with them most of the time. So you're really going to pick up on a lot of things when they're there visiting. And a lot of times spouses spend the night. So then we'll talk to the bedside nurses and the staff and be like, hey, how are things going? And our all of the staff they're really just good about having that conversation with the family member if it isn't safe, and kind of having that plan. We'll do like family meetings if needed with say it's like a son or daughter family member, or even power of attorney if that comes into play. Yeah.
I think from a perspective of as a family member and then also as a coach who works with a lot of families, I usually offer that is our first area of opportunity to get some other interventions and resources pulled in. So like if they've gone to the hospital and the spouse is like, oh, I can take care of him at home, but then the adult child is in the room like shaking their head, no, it's not working.
Yep.
That's kind of the signal that maybe we need someone to be admitted.
Yeah. Yeah. And that's, like you said, it's a red flag, and we'll follow up, whether it be social work or care coordinator or even that staff nurse. We kind of work as a team, and that's what's good about a lot of the hospitals and all of them. I mean, it's a team approach. It's not just one person being like, you need to do this. It's everybody meets, and it's a team effort.
So let's say we have managed to get someone admitted. What, as of November of 2025, what are the current rules around Medicare covering rehab?
So it depends on your insurance, obviously, but there's definitely a rule that you have to have the 3 midnights, 3 hospital stays overnight. And there's also another portion, which I'm not super familiar on how all that works, but there's a Medicaid or a waiver program, excuse me. So then there's certain places or rehabs that person qualifies to go. I'm not sure of the logistics of that, but that's usually the 2 options. And then the big portion is therapy has to recommend it. So if somebody needs rehab, well, we have to prove it in the paperwork. We can't just be like, everybody gets to go to rehab, because insurance will not cover that.
Okay, so our first goal is to have 3 midnights in the hospital, and then we're having conversations about what's next and where to go.
And honestly, in my role, when I did that, it would be a day 1 conversation. So we always kind of want to plant the seed and say, these are the options. These are the things that can happen. Let's start planning ahead and start looking into options and going over all the possibilities. Because you don't want to wait till the very last minute to do that, because then we don't want that person to be stuck in the hospital longer than they need to.
That's fair.
Yeah.
I think what's hard about that is, as from a family perspective, is sometimes people come into the hospital and maybe they're disoriented or they're experiencing some delirium.
Right.
So at what point, if on day 1 we're talking about wanting our person to go to rehab, at what point are those referrals being sent out? Or I guess let's even just, because I feel like I'm starting to talk like I know what I'm talking about. Let's talk about what is the referral process.
Right.
I know just enough to be dangerous or annoying.
Sure. So, in healthcare, we all know that documentation is important, and you're going to get a picture of what's going on by how you document. But I will say, like if somebody has a dementia diagnosis, it can be a challenge sometimes, because we all know that person's going to be a little confused at baseline. But say they have some sort of infection or something like that, and they come in and they're completely not themselves. Well, on paper, when we're documenting, it's not going to look amazing to anybody.
Mhm.
So it also depends on the time that they come in. If they came in on a Friday or Saturday or Sunday, we're probably not going to send referrals because it's a weekend. And if they come in on that time, there's not going to be a social worker assigned to them pretty much. So I would say really, we try to send out referrals as soon as possible, but if somebody is not ready for discharge or in the near future, in the next couple of days, they're not going to be ready, we won't send referrals because there's got to be some like big changes for them to be able to discharge, whether it be their mentation or they haven't even sat up from the bed, they haven't eaten anything. Those are the biggest barriers. But until we start making progress, then we will start sending the referrals to the rehabs.
And in my experience, if someone has had a bed alarm on because they're repeatedly trying to get out of bed, or if someone is maybe has had someone coming in, and I don't love calling them a sitter, but that is
like a care companion.
like a care companion. So those
Yeah.
are those two red flags for the rehab places?
It can be, again, if we have to kind of look at the big picture with the rehabs and the social work and care coordinator. We all kind of work as a team because, again, if they have dementia and they have a urinary tract infection, they're going to be way confused and they're going to have that care companion until they clear up. So there's usually a rule for, it depends on the place, but usually a rule within like a 24 or 48 hour period, they have to be care companion free and then they'll accept them. So we, at the hospital, we try our very best to, wean that person off as far as a care companion goes, or say, oh, let's only have them at nighttime today and try all that and try to get that care companion gone as soon as possible. But as far as alarms, I would say 90% of our patients have alarms in the hospital because everybody's pretty much a fall risk and it's just a safety thing. And we tell our patients, we need to be with you at all times in the room. Unless it's like, it's very rare if we have somebody who's not on alarm. So the alarm thing, I don't think is a big deal anymore. It's more the care companion thing.
Okay.
Yeah.
So how many referrals are we allowed to send out, have sent out? How many can y'all?
I couldn't tell you how many there are in the Omaha area, but it could be as many as you want.
Okay.
I mean, we could be like, hey, how far out do you want to go? Do you want to go to Council Bluffs? Do you want to go out west, an hour, 2 hours away? We can send it wherever. It really is just based on that conversation with the patient and the family and who's accepting their insurance, where's the most appropriate place for them. Because if they need to go to a place like Madonna or something like that, where it's a more extensive kind of rehab versus just like a basic rehab, then that's a whole nother story. So really just communicating with the family and patient, but yeah, it could be anywhere.
Can you make recommendations on places?
Technically, no. So what we say with that is there is a website called medicare.gov and people can look at that and look at the reviews. But if you're local and that person is local or trying to stay local, we'll say just show up to the rehabs and do a tour. Don't call ahead because if you just show up, you're going to see how it really is there versus when you set up a tour, everyone's kind of on their best behavior. So, yeah, I mean, we can't technically, because it would just be a biased opinion. And we would hate if we thought someone or a rehab was amazing and then somebody else thought it was horrible. And it could be based off just one experience, good or bad. So yeah, we give them a list and say, these are the ones that are covered. And then we kind of have them look into them and we try to narrow that down as much as possible and who has bed availability and and things like that. And then they hopefully can go visit them and get a better eye to see what it's going to be like.
Are there things that family members can do to make their person a better candidate? Because I heard geography and insurance are two big, and then care needs seem to be three big components. Is there anything else? Like if the family's extra nice, does that?
I mean, that's helpful. No. I mean, yeah, being nice, of course, that's a big one. But I would say sometimes it does help if, like, say as the care team, we are sending out the referrals and not getting a response, for example, from a place that they really want. I don't think it's going to hurt for the family member to call that rehab and say, hey, so and so sent out a referral. We really are interested, and try to like talk to the director or DON, whoever would take that referral. So that does help. But other than that, they like the documentation of what the doctor has to say and what the therapy department has to say. So is that person progressing, meaning are they getting better each day with therapy? And do they have sort of the potential to do rehab? And there's a lot of times, which is super helpful, but there might be people that just are at rehab for 1 to 2 weeks and that's it. And we don't want them there for months, but just enough to be safe to get home or have a solid plan when they get home.
I think to have a solid plan is so important, because I like having, I'm not a clinical person, but if it's appropriate for someone to go to rehab and it's just family resistance because they're anxious to get someone back home, but they're not set up for success, I really like it when families make that decision to use rehab, because it helps people get stronger and buy some time.
Right. Definitely.
Yeah.
Yeah. And like I said, if you have a good team, which I've never really been in a scenario where a team member isn't gonna, like, they're gonna tell you how it is. They're gonna say, hey, you're really not safe to go home because therapy doesn't think so, the doctor doesn't think so. So you going home is gonna put you at risk for falling, getting hurt, whatever it may be. If you go to rehab, you can build up that strength, and the odds of you coming back to the hospital are going to be a lot lower. So that's what we really encourage, and just, tell them how it is, and be open and honest, really.
Because the hospital does not want people to readmit within a certain period of time. How many days?
I can't remember how many days.
30 days.
I don't know if it's
2 weeks.
I don't know if it's 30 or a week or two. I'm drawing a blank on that, but either way, we always have, like, where do they go? So if they go to rehab, we would have them follow up when they discharge from rehab with their doctor within a week. And if they go home, we have them follow up within a week as well. So our hope is that anything that's like straggling, or if they need a little extra help with something, they can just follow up with their primary doctor and get their help if needed, and stay out of the hospital is the goal. But we all know accidents happen, people fall, and just accepting that help, because after rehab, or even if you go home, if you need it, which a lot of people do, we would recommend, like, maybe you need some home health care where it's covered by insurance, where therapy comes into your home. Maybe you need private caregivers. Maybe you need extra resources or Meals on Wheels or whatever it may be. So just our job is to help that person get to where they need to be and give them the resources, and honestly, the family, the resources too.
I mean, to that point, I feel like when someone goes into the hospital, this is our time to leverage the third party people.
Oh, yeah, for sure.
Conversations. What are some of the tough conversations that discharge planners are having to have with families?
I mean, there's scenarios where we're having, whether it be us or the doctor, whoever, saying there's no way you can go back home, like ever, or
Mm,
just it's really hard for people to accept that because they have been to the hospital month after month with the same thing over and over, getting calls from neighbors or whoever it may be, and to where it's like this isn't an option anymore. And again, we cannot force people to do anything. We can highly recommend it, but it's just having that heart to heart conversation with people and being real, and just sometimes we might have to bring the chaplain in. Sometimes it might be a different doctor if we need a different approach. Sometimes it might be a palliative hospice approach. You know, there's a lot of different things, but just making sure that person gets the resources that they truly need. But yeah, there's a lot of hard conversations, and I would say a lot of them are with just the patient thinking they can take care of themselves, or the family. They want to take care of them, but they physically can't anymore. If you're, 95 years old, you can't be picking up your spouse anymore. Like, and if they're falling and you can't pick them up off the ground anymore, like that's just not safe for anybody. So just kind of educating. And I think my strength, and a lot of my friends' strength and people that I worked with in the past, like we just sit down and listen and have conversations. We don't come in and say, you need to do this and you need to do that. It's just being there and being an advocate for your patient, I would say. Yeah.
well, I think I have been on the receiving end of so much great guidance from hospital team members. I remember my father-in-law, he was only 75 when he passed away. So we weren't even in the 90s, but it just got to this point where he was not necessarily meal prepping anymore. And he really, because he was receiving chemo and doing some infusion therapy, so he was not really able to successfully, like he could putter around his house, but he couldn't really take care of himself.
Sure. Yeah.
Yeah. I think it's something I think is so critical is when an adult child can be present for when doctors are rounding.
Yes.
What time of day generally are people coming by the room? Because it can be so hard to get a hold of professionals. Yeah.
I think that's the hardest. We have patients, family members who sit in there all day, and then they go to the bathroom, and then whoop, here comes somebody that they want to talk to right in the door.
Yeah.
So, but I always tell people morning, like I don't know, like maybe around 8 or 9, but then you have doctors who come at 5 and 6 a.m. So if there is an important conversation or you just want updates, I just encourage the family to reach out to the social work care coordinator team or even the nurse, the bedside nurse, and say, hey, can I please have a call from the doctor? We are more than happy to do that. Anyone from the team can give updates. And we do that all the time. We would just give updates to families and call them almost every day. So, but it just, like I said, it just depends on the doctor, the person, all of that. There's really no specific time, unfortunately.
I know when our daughter was at the children's hospital for a couple of weeks, it was the doctors and the residents would come by. It was like, I tell you, 5:45 a.m., but we were sitting there with her. So yeah, because they're,
in there before they go to surgery all day. It's either 5 a.m. or 5 or 6 p.m. So yeah, it just depends. For sure.
Take into account. What if you really want someone to go to rehab, but they're not making any progress in the hospital?
So unfortunately, it's up to insurance. So if insurance says no, then they can private pay and go. But I can tell you 75-80% of people are not going to privately pay to go to rehab because it's pretty expensive. and we would just do our very best to set them up for success at home. So meaning home health care therapy. Medicare only covers them therapy to come out like 2 to 3 times a week. So it wouldn't be every day like it would at rehab. But between that, maybe a family member who can check in on that person, and hiring like private duty caregivers, something like that, we would help coordinate all that. But yeah, sometimes it does, like it works out where that person can't go to rehab because they're just kind of plateauing, and insurance doesn't like that sometimes. Yeah.
So are you able to make recommendations for home health companies or other resources in the community?
No, it's the same kind of thing. It could be like a biased opinion and whatnot, but we will first, we always ask, hey, did you have a home health care company in the past, and were you happy with them? And if not, we'll say, do you have a preference? And then if not, then we will just send a referral to all of them. And then we can say, these people accepted which one. And then they'll be like, oh, just pick the first one who like accepted me. So we'll communicate that with them, and or give them the options of the people who did accept them as a patient. But again, we can't refer. Same thing with like assisted living locators. If there's a few companies out there, we can give them a list. Home care companies, same thing. We just have to give them a list, and then they have to kind of do their research.
Okay.
But I will say, sometimes there's not family. Sometimes that person can't see. They're not going to be able to call. So there might be times where we have to make those phone calls with them, which is totally fine. Or look up rates online, or call around and see who can provide 24/7 care, because if that person can't do it themselves, they need somebody to help them. So that would be more on the social work care coordinator side.
What is your caseload at the hospital? Because I mean, we're obviously so self-absorbed with our own family members. I mean, how many people are you trying as a hospital discharge planner or social worker working with at any given time?
I would say on average, it kind of ranges on capacity with the hospital and everything, but it could be 20, 25-ish on a very high census day. It could be up to 30, but again, you're not seeing every patient every day. It's the highest need. If that person's discharging, do they have everything they need? Do they know what time they're leaving? Versus somebody who's completely independent and they don't need anything. So I would say out of the 20, you're probably gonna at least see 10-ish that day. So some days it can be easy peasy, and other days it's not. And you just have a lot of challenges. So it really just depends.
Are there better questions we could be asking you to make the process more smooth? Or is there better information we could be providing you to make that process go more smoothly?
I think just painting a picture for the doctor and the care coordination team of what reality looks like day to day, and what that patient struggles with. Do they need help with meals? Do they need help with whatever it may be? And just having that openness of like, don't be embarrassed. Don't be scared to tell me that you need help, because when you're here in the hospital, I can provide those resources. But when you go home, say you call me, I can still help you, but it's going to be a lot more difficult. So say, for example, someone's like, no, I don't want to go to rehab. Then they go home and they're at home for a few weeks. And then they're like, oh, I changed my mind. I want to go to rehab now. It's a lot more difficult to make that happen when you're at home. It can be done, but it's just, yeah, being more open and having that honest conversation of what you truly do need. And there's a lot of resources out there different websites here in Omaha and different places, organizations that provide free resources. There's veteran benefits. There's a lot out there that I feel like a lot of people don't know. So most care coordinators and social workers will ask those questions to see if you qualify for certain things. But you also have to say, hey, I need help with taking a shower. And then you might get a free service out of it. Or home health care can come out. So yeah.
It's so I guess fascinating. Like usually when we go to the hospital, we are obviously in pretty terrible shape. Like nobody's going to the hospital if you don't need to go.
Right. Nobody wants to go there.
Nobody wants to go to the hospital. But by the end, I think people can be feeling so much better that they're like, I'm fine. But the reality is, unless sometimes we pull through some of these additional resources, you're going to end up back to where you felt at the beginning.
Right. And yeah, and just doing, and that's why I love therapy, is just communicating with them and say, hey, they think they're ready to go home, but I have a feeling they're not. And then they'll do stairs with them. They say they have 20 stairs to get to their apartment. Well, you can go home if you do the 20 stairs, but let's see if you can do it. So they'll do things like that. They'll make sure they can get dressed by themselves, walk around the hallway, all of those things, get on and off the toilet. And if they can't, usually that person realizes, hey, I'm not quite ready. And sometimes too, like say we're in a bind, worst case scenario, and that person's on the fence if they want to go to rehab or just go home. Our bedside nurses or the CNA, they can walk that person or do whatever needs to be done. Say therapy's gone for the day. So like I said, it's everybody's always willing to help and have the best plan for the patient.
And when you're saying therapy, we're talking about speech or like occupational therapy, physical therapy.
Yep.
Okay.
Yeah, and there's times that unfortunately, like somebody wants to go to rehab, and then they change their mind last minute, and then they're like, oh, I want to go home, and then it's Friday, like Friday afternoon, for example. This happens a lot. But then they change their mind again and they say, oh, never mind, I do want to go to rehab. Well, now it's Friday at 4:00, and now we have to find another rehab to accept you. So now, unfortunately, you're going to be stuck here the weekend. So again, timing plays a role in it, but just like I said, just having that solid plan and seeing what the best case scenario is for that patient helps.
I also have made the recommendation if they are wanting a specific, like let's say someone has gotten into 3 rehabs, but there's others that they would really, really prefer or would work better for them to stall, like literally have the family stall so that we can find out if we can get into one of the preferred places. So even if that means staying in the hospital an extra weekend.
Right. I think it really depends on the whole scenario. There's sometimes that's okay, and then others it's not. Like say they've been waiting a week to get discharged and they have 3 accepting places, and that one they want to go to, they aren't accepting yet. That doctor might push that because sometimes insurance won't cover you to stay there if you're medically ready.
Okay.
But again, it just depends on timing. It could depend if it's a Thursday or Friday and you're not ready to be discharged till Monday. Well, then you can stay the weekend and we can figure it out on Monday. So like I said, it's just scenario based, but
I feel like it never,
all the doctors, they do a good job of working with the families. But again, there are some times where the patient or the family is not ready for that person to be discharged, and Medicare or whatever insurance will say, no, you're ready for discharge. They could technically appeal it, and sometimes the appeals take a few days. That could keep them in longer. So that's an option, but not all the time does the appeal go through. So that could buy people a few days, but you gotta jump through some hoops to get that appeal.
Fair enough.
Yeah.
And I mean, obviously, if a doctor's like, no, they're out, they're out. There's nothing you can do about that. But if they determine that it's reasonable to keep them, to
Sure.
continue to
Yeah.
treat them, I don't
Mhm.
want. I'm not indicating that doctors are not doing their job.
No,
That's
no.
what I'm saying. Yeah.
No, I know. Yeah. If they're not ready to go, they're not ready. And if it's questionable, sometimes they'll say, well, let's just keep them the weekend.
Okay.
It really is like just kind of the big picture.
Yeah.
Yeah.
Is it legal for the hospital to discharge someone if they do not have a safe discharge plan?
So technically, it just kind of depends. So, like, say we've done everything and we've offered everything, and that person says no, well, they can still go.
Mm,
You get them every resource. Maybe they're homeless. Maybe their living situation is not like their house isn't tidy or not safe, and they're refusing things. Technically, they can go, but we might have to call APS or something like that and make a report to where it's not safe. And or people can leave against medical advice where they just sign out and say, I'm done, bye. And they don't have a plan or anything.
mm.
So it's unfortunate when those things happen, but they do. And like I said, there's nothing we can do about it, but we just throw like literally all the resources at them so they have them. And if they decide not to use them, then we can't force it on them. Yeah.
Are there frequent flyers?
Yes. I've been a nurse for 10 years and I've seen a lot of people that are frequent flyers.
So I know, like, what do we think that means, I guess?
I would say just people who are not compliant with whether it be medication, oxygen, people who fall, people who don't go to follow-ups, who don't take their
Mhm.
insulin, um, and just people who don't take care of themselves or have like a support system, I would say. I think the support system is huge. If they don't have family, then who else is helping them or even checking on them and making sure that they have everything they need at home. But yeah, it's unfortunate that we get those, but we keep trying. And like I said, sometimes people change their mind and they're like, okay, fine, I'll go to rehab this time. Or
Mhm.
okay, fine, I'll move into long-term care or assisted living, but not all the time.
So if as a family there is an uptick in how often someone is going to the hospital, that is really an indicator that we need to be doing something
Mhm.
different. It's time.
Yes, 100%.
Yeah.
Yes. The more that person goes in the hospital, the more attention they need, the more resources they need. So if they're constantly going, what they're doing is not working. So they need extra help for sure. It could, like you said, it could be going to rehab, it could be going to assisted living, independent living, or getting caregivers, or having somebody help you navigate where to go. It's all of the above, but it really, that person has to be accepting of it is kind of the hardest part sometimes.
So, as a nurse who has been in this industry for so long and you've worked in multiple areas within the industry, you have found a need that people have.
Yeah.
And so you have started a company to work to fill that need. Tell us a little bit more about that.
Yeah. So my company name is called EverBlessed Nursing and Transport. And I wanted to create something because I love being a nurse and I love the one-on-one care, but as a nurse in a hospital setting, or really a lot of the settings, you don't get that. And you're kind of like, oh, I got to go here and then I got to go there. And I really wanted to hone in on just like private nursing, where I would go to the person's home and provide skilled nursing services. So say they have a catheter that needs to be changed, wound care, something with a feeding tube, providing education to the family. Those are all things I would do. And then I would just contact their doctor and communicate with them. Also, if they lived in assisted living, the nurses there can't provide those services. So it either has to be like a home health care, where if it's home health care, Medicare will cover that, but they don't cover it every day. So say somebody needs a daily flush of a drain. Well, they're not going to cover that every day. They might cover it twice a week. So then I can kind of fill in the gap with that on the off days. But again, I won't go through insurance. It would be private pay, but maybe that patient can't do it themselves or the family member's not available to do it. That's kind of where I would come in. And then the other side of it is there's always a need for transportation for, again, my target is going to be 65 and older because that's just my passion. And there is just a need for transportation with a wheelchair specifically. Like there's a lot of people that get discharged from the hospital in a wheelchair because they can't walk more than 25 feet or 100 feet. So I'm going to have a van with a wheelchair lift in it, and then take people to and from appointments, go to the appointment with them, like sit in there with them if they need somebody there, and take them home from the hospital. And maybe they need to go to dialysis or home from dialysis, things like that. Maybe they had an outpatient surgery that they didn't have to stay overnight. I can take them home from that. So those kind of things where family members are not available, maybe they live out of town, or they're just like, oh my gosh, I don't know anything about anything medical and this stresses me out. That's where they could call me. So I'm very excited about it. Like I said, it's going to be one-to-one care, which I'm excited about because that's my passion. And I love getting to know people and talking to people and hearing their stories. So that's why I'm doing this, is because then I can actually sit down and take the time to do that.
I love it. And I think so often, even as family members, I don't know the medical jargon and lingo,
Right.
or like what actual choices mean. So if there's a big appointment where we're going to have to make some different decisions, obviously the doctor and their nurse are there to help us with that. But sometimes we don't remember everything.
I mean, I've been to appointments of my own or with, my parents or grandparents even, that I'm literally sitting there typing out notes because they throw out all of these options at you and then you leave and you're just like, what happened?
Right.
So I write things down, then I can go back and look at it later because sometimes it can be very overwhelming.
Yeah. So just having someone who can recap and interpret and then give that information back as a family member would be so helpful. And I think there's this whole population of people that have no children and don't have a spouse, and how valuable that would be to have someone like you that's part of their care team.
Yeah, definitely.
Yeah.
I think that is a huge need because they're, like you said, they might live out of town and they might just not have anybody here. So just one call away.
Yeah. Well, that's great. I think we've talked pretty extensively about like getting admitted to the hospital and the discharge process. Is there anything that you would like to say to family members that are listening to this and who are trying to figure out kind of what's next?
I would just say working with your care team and having that honest conversation and real conversation and truly doing what's best for that person. There might be somebody who has advanced dementia and therapy is like a little on the fence about them going to rehab. Maybe a rehab accepted them, but with their dementia, they're not probably going to do well at the rehab. So having that open conversation of, what does it look like when you go to rehab? versus what does it look like when you go home? Because going to rehab might cause more confusion. It might cause them to be delirious, and they might, it might take a few weeks for them to even get used to being there. And then Medicare might not cover them to stay because, well, they're not participating in rehab. So you just have to kind of think ahead and assess each situation and just really be open and honest with the family members, because we want the best for each person, and we don't want to send somebody somewhere if it's not going to benefit them and be the right thing for them.
Perfect. What is on your playlist right now? What are you listening to?
Oh gosh, I'm not listening to anything right now.
I'm listening to the Inspired Caring podcast.
Right. I did click on it the other day for the first time, so
Perfect.
I'm gonna have to start listening.
Subscribe so you can hear more great episodes like this one with Steph. Steph, how do people get a hold of you?
So I am creating a Facebook page, and it'll just be EverBlessed Nursing and Transport. And my email is EverBlessed N and T spelled out at gmail.com. And yeah, I would say just email, Facebook. You can message me, and I'll have a Google ad out there here soon. And yeah, it'll be great.
Perfect. Well, thanks for being here today. I think this was really helpful.
Thank you. I appreciate it.